Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day. Behind the Knife would like to thank Boston Scientific for sponsoring this series. Boston Scientific's EduCare platform provides online access to a wealth of educational and training content all in one convenient place. Boston Scientific is committed to making medical education and training more relevant, more comprehensive, and more accessible for healthcare professionals like you, helping you deliver the best patient care possible. Visit educare.bostonscientific.com. That's educare.bostonscientific.com to start your learning journey today. Welcome back, and thanks for tuning into our fourth episode in the surgical endoscopy series for Behind the Knife. In this episode, our focus will be on endoscopic management of complications. Although our team was originally based out of Endeavor Health, which is in the northern suburbs of Chicago, we are now spread out all over the country. For a brief reintroduction, I'm Sully Ayuso. I'm now at the University of Texas. I'm a minimally invasive surgeon there and an assistant professor in the Department of Surgery and Perioperative Care. Once again, we are lucky enough to be joined by H. Mason Hedberg from Endeavor, who also has an affiliation with the University of Chicago, and Dr. Trevor Crafts from the Rocky Mountain VA and the University of Colorado in Denver. In the last couple of episodes, we've also brought on a guest, and this week we are very excited to have Dr. Zachary Callahan join us. Dr. Callahan, like the rest of us, trained under Dr. Michael Ujiki at Endeavor, formerly North Shore, and is now assistant professor and also the associate program director for the residency at the University of Tennessee in Nashville. Like the rest of us, Dr. Callahan employs surgical endoscopy regular in his practice. So Dr. Callahan, welcome to Behind the Knife. Thanks for joining us.
Yeah, thanks so much. It's honestly an honor to be here. I've been listening to Behind the Knife for well over 10 years, so to be able to be on this show, it's honestly a bit of a dream for me. So thanks to Sully, and it's good to see everyone else again.
Excellent. Trev, you want to take it away?
Absolutely. So in this episode, we will talk about the endoscopic management of the unexpected, so intra-procedure and postoperative complications, and hopefully it will offer resources and options for all of you as trainees and practicing surgeons in these feared and difficult situations. Specifically, we will plan to focus on the different types of tools that are available endoscopically and how they can be applied. We will review different techniques, namely endoscopic suturing, clip application, stent placement, and EndoVac therapy. Most of the conversations that we're going to have will be centered around foregut surgery, since that's kind of a collective shared focus for us, but certainly some of these things are pertinent for the colon and lower GI tract as well. Specific clinical scenarios that may benefit from the use of advanced endoscopic techniques include things such as anastomotic leaks, sleeve leaks, perforations, iatrogenic injuries, and stenoses. Although these techniques are well described and relatively efficacious, it's not always clear where they land in terms of the board or safe answer. And as such, the first hurdle to overcome is learning to think endoscopically and be aware of what could be done. Are there endoscopic options that could help us avoid a potential major surgery for this patient? Is it a safe and appropriate technique for the patient at hand? And this is what we hope the surgical community will aim toward as we kind of more globally enhance our endoscopic capabilities as a profession. Operations for patients who have iatrogenic complications or postoperative surgical complications can be the hardest types of operations to perform, often with a high rate of conversion to open, prolonged length of stay, and significant morbidity. So learning how to perform these different endoscopic techniques allows surgeons to add a tool to the toolbox and potentially decrease morbidity for patients. With all the talk in publications about what type of minimally invasive repair is beneficial for patients, whether it's lap or robotic or what have you, we believe that a focus on endoscopy can make surgeons even more complete caregivers for these patients.
Awesome, Trevor. Zach, you want to start us off talking about endoscopic suturing? I think it'd be really interesting to hear your experience with learning this skill set and then how you apply it in practice every day.
Yeah, thanks, Sully. Yeah, so most of what we'll talk about today focuses on a device called the Overstitch. Important to recognize that there are other endoscopic suturing devices. This feels like a new device, I think, because endoscopic sleeve gastroplasty is is gaining a lot of steam. But it's a pretty old device. So the first generation I think was around 2010 or so. And I wrote a paper in fellowship and I pulled up some old pictures of that device, and the new one is definitely a little intimidating. There's a lot of moving parts, but that old one is impressive. There's a lot of like long catheters and long strings. That thing looked kind of miserable to use. And then they also just came out with all the old ones rely on a double channel scope, but the new one, the NXT, is out and it is on a single channel scope, which is kind of a big deal. I'll tell you that when I started practice in Nashville, there was not a lot of advanced endoscopy, so I've kind of had to fight with the hospital to get different things, and even getting something like a double channel scope is extremely difficult. Anyone that's tried to do that is aware that Apollo has stopped making them. How long? I mean, years ago. And I've been hearing for like 5 years that we're coming out, and they just haven't come out with anything else. So that's been a major limiting factor. So certainly coming out the NXT where it can be on a single device, a single channel device, is a big deal. Do want to point out that the reason this device was different, it has to do with full thickness defect closure. So certainly we have our hemostatic clips that we use all the time, but we really didn't have a good way to close something that was full thickness. And the first device that came out was the Evesco clip. So this is a device that you'd basically have an instrument that would go through the device. You could grab tissue edges and then clamp that thing down. And for small defects, that worked really well. And the overstitch kind of extends on that idea that, through one of the channels, you're using a device that's going to grab tissue, pull that tissue into the overstitch, and then fire stitch full thickness through that. The OG fellow at North Shore Endeavor, Mike McCormick, would always say you want to feel that Polish pop. And what he's talking about is, when you drive that needle through the tissue, when you actually are getting full thickness through the serosa, you feel kind of a little bit of a pop, which, being in Chicago, you have a few Chicago docs, et cetera, so we call it the Polish pop. Anyway, so most of us, at least as surgeons and bariatric surgeons, our exposure to the device occurred mostly with endoscopic bariatrics. So both the TOR procedure and then endoscopic sleeve, both of those procedures, as you can imagine, really require full thickness bites. I mean, if you're taking non-full thickness bites of the stomach to compress it to make it into an endoscopic sleeve, you can imagine that it's not going to last very long. But it has a lot of uses. Another nice place is for those that do third space endoscopy. I find it's way too big to do for Zenker closure, though I've tried in desperation. I think I called Mason during that one. And then in the esophagus, it works, but is also a little bit for G-poem. So G-poem's really nice because you end up, with the stomach, it's really kind of like thick mucosa. So overstitch can be super helpful. I forget the cost cutoff. It's something like maybe more than 5 clips, I want to say, or 6 clips. But once you get above that clip amount, the overstitch is cost effective. It works in the same way. Certainly if you're in trouble, and I submitted some videos to Sully, there's a great video. I think I stole it from Chris Zimmerman actually, but there's a great video of a EMR. It's like duodenal bulb, maybe D1, whatever. Get a good lift on it. They throw a snare under and they rip it open and you're just looking at pancreas. I mean, it's this huge hole and you're just like looking extra peritoneal. Have you guys seen that video? You haven't seen that video?
No, I
man,
can't wait.
okay.
We'll share it with
All
the
Yeah,
viewers.
you guys got to check it out. It must have been Chris's year, but it's incredible. I mean, in someone else's hands in another part of the country, you're calling general surgery. That general surgeon's giving the patient exploratory lap, right? They're getting an X lap, Whereas when you have the endoscopic skill set, like we're all so lucky to have, they just threw the overstitch down, took some bites of it, cinched it up, and sent that patient home, I think, same day. So it's obviously super helpful for things like perforation. The other thing, and I was talking to my residents about this the other day, when we see perforations from like gastric ulcers, we're talking about tissue that is inflamed and angry and been sitting in pus and bile for all this time. So, closing that is hard. But when there's an iatrogenic perforation, I mean, that should heal like really well, right? That is fresh tissue, healthy tissue. The patient isn't, a COPD that's on, Eliquis, whatever. So, when it's an iatrogenic perforation, honestly, those are some of the easiest saves for us. And you're also a total superhero because the person that created that full thickness, defect, that's the worst day of their life. And if they can call you and you can go in there and save them a big operation, there's nothing. And I fondly remember Mike Ujiki doing this a few times, they'd call for surgery for like, perforation in the GI suite or something like that, and they call us and, they expect us like take into the OR and Mike would just kind of go up and just like take the scope out of their hands and then just like go back down, and like close it up. And there's just something kind of fun about that. I'll just finish and talk about we published this paper, and the idea was there's an Ovesco paper that kind of published the first 100, 150, whatever cases, different utilities of the Ovesco clip, looking at, fistula closure, looking at defect closure, etc. So we kind of tried to do a similar study looking at overstitch. So we looked at 150 different cases that used the endoscopic suturing device. So we had to kind of dance around using overstitch about 100 times in that paper. So it goes. And the short story was that, technically speaking, it worked well. It's like high, like 90, 97%. But in terms of actual clinical success, meaning the thing we were trying to do actually being successful, it very much depended on, what was the indication. So, the overstitch is a great device. It's not a silver bullet. So if someone's had, a GC fistula for the last 30 years from their malignant whatever cancer, yeah, if you overstitch that close, that's not going to work. But certainly in appropriate uses, it works very well, especially with things like stent fixation. I see a lot of migrated stents that could have been prevented just by a few stitches. All right, that's pretty much all I can think about.
That's an excellent overview. I think that's just such a versatile tool to close both, planned and unplanned defects, but you got to get facile with it before you widely apply it.
Which is way easier said than done. I mean, there's definitely, you have to get past the phase where you're thinking like, okay, do I push, do I click, do I, et cetera. So
right, when you have a lot of area in the stomach, et cetera, that's probably the best way to kind of learn the tool, rather than try to close semi-iatrogenic esophageal perforation late at night. But the applicability is wide for sure. So I'm excited for this next part because Dr. Hedberg, I think and think about surgical endoscopy as well as anybody that I know, talking specifically about clips and stents and how you use them in your everyday practice. Very interesting here.
Yeah, thank you very much. I wanted to piggyback on Zach a little bit in terms of, hero moments in the OR. That overstitch can go in either end of the body. So I had somebody, it was an aqua ablation, rectal perforation, same thing. We just put the endo stitch up there, one figure of 8 stitch, and enema looked good. Guy went home the next day. So it's a great tool to have. So in terms of clips, we all know the little hemostatic clips. There's a lot of different varieties of these, different widths and different kind of grabbing tips to grab the tissue. These are good for kind of superficial mucosal tears. You really don't want to. Some of these clips are designed for full thickness defects, but in general, we're using these to stop bleeding or close little mucosotomies, not full thickness injuries. We'll use anywhere from 4 to 8 of these when we're doing POEM to close the mucosotomy, depending on how big that hole gets. Works really well. The mucosa heals quickly. The clips just fall off. I will say there is a newer clip. I think it's called a Mantis clip, but it has these really gnarly, hooks on either side. It opens up really wide. And this is actually, they're marketing it as a closer device, not a clip, not a hemostatic clip. And I don't know if it's out yet, but I was reviewing Sage's abstract videos and I saw somebody close a rectal stump blowout with 11 of these clips. And it healed great. It was after a Hartman's in an acute setting, and it worked fantastic. He's in there in the peritoneum watching out the. You use the Mantis clips?
Yeah, you guys? I don't know why we would have it. We don't have anything, but for some reason we have Mantis clips. But it is sweet. It's a little tricky though. Like how with the over the scope clip devices, you can kind of grab one side, grab the other side. With the Mantis, you have to be a little creative, and you kind of like pinch one side and hold them in it, and then you have to kind of drag it over to get the other side. So it works well. I don't know if I would do it for the rectal perforation 11 clips, but it's a neat tool for sure.
Yeah, it seemed good in those little tight spaces. I mean, this rectum didn't look fun to be in terms of the video, and trying to get an over the scope clip and really get the whole rectal perforation in that clip would have been tough. So that was a unique circumstance, but I think we'll be seeing more of these technology. The technology will advance. There'll be better clips. We did already go on those talk about the over the scope clips a little bit. The other tool that I don't know that we mentioned is again, you got to use the dual lumen scope for this, but there's a grabber thing like Zach mentioned, grab one side and the other. And there's another one that just kind of shoots out barbs radially. So you can put that into a small defect or a fistula tract and really pull that whole tract into the clip before you deploy it. Before I get to stents, I didn't see it in our agenda here, but I think we have to shout out to internal drainage. So some of these, defects you can close either suturing or with clips. Sometimes there is an indication specifically for internal drainage, like a sleeve gastrectomy leak. That is now the preferred way to manage these. So when you have a relatively small defect and an abscess cavity on the other side, rather than going to the OR and washing out, try to close this thing, we just put these little double pigtail drains into the abscess cavity. So one end of the pigtails in the cavity, one end in the lumen, and it just allows the abscess to drain and it slowly collapses from the outside in. So I've had a couple circumstances where I use these, and it is a lifesaver if you know to think about it in the right circumstance. You put it in, the patient can go home, they eat, they don't even know it's there. They get a CT 2 months, 2 months later or so, the cavity's collapsed and the drains are still there. You just go in and pull them out. Sometimes they just fall out and pass through. So that's a good tool to have. And you can stent around these. I have not done that, but if you have kind of a big defect and you're worried about more food or something getting in there with those drains, you can put in a couple drains and then stent to really occlude it. The pus will kind of drain around the stent. It'll depressurize, but you're also keeping other food debris and stuff from getting in the abscess cavity. So there are multiple kinds of stents. They all have different indications. The most common one, at least in my world, is the wall flex esophageal stent. So these are pretty big. They're 18 millimeters wide up to 23 millimeters wide, about 10 to 12 centimeters long, designed to cover at least a third or more of the esophagus. They come in a couple flavors. So fully covered, that's for what we're using most of the time. It's something you intend to come back out. Then there's partially covered, where the ends, the distal and proximal ends of the stent do not have a coating on them. So I'm using that, and most often in a palliative kind of setting, if there's a bulky tumor that's obstructing a lumen, you put in the partially covered so the tumor doesn't grow into where the coverage is, but also that stent's not going to migrate. So that's less so for our complications or acute settings. The fully uncovered, or the uncovered stents, I've never really used. There are some duodenal stents that are uncovered and actually go through the scope. So in particular kind of circumstances, that may be useful if you're in a tight spot and you can't get a big stent in there. And then there is a different kind of esophageal stent I learned about recently, and they come in shorter sizes. So I used a 6 centimeter one, and a patient had a kind of a small sleeve gastrectomy. Actually, I put in a 10 centimeter one first, and the distal end was occluding the pylorus. So we pulled that one out, put in a 6 centimeter for this strictured area that was healing, and that one worked pretty well. So they're coming out with more and more varieties of these for specific circumstances that can be useful. And then finally, one
fluoro every time, or how often use fluoro? Do you sometimes use it? Yeah.
Yeah, good question. I think these things are expensive, and if you don't get them in the right spot, it's hard to move. So I'll describe the deploy process just briefly, but they come on kind of a big rigid catheter. So you come down with your scope first, put a wire across. I'm usually using fluoro, so I make sure the wire is really deep in there. Back your scope over the wire, and then you advance this giant catheter down, and there are markers on the catheter that are radiopaque, so you can see your distal and proximal ends of the stent. And then usually, with the scope down in there, you're clipping some hemostats or something on the patient, so you know where your strictured area is and where you want your landing zone for the stent. But then you deploy it. So once it's in place, you got the distal end in first, and you're pulling a sheath back over the stent. So you see it start to expand and open distally first, and then you're trying to adjust that distal landing zone as you continue to pull the sheath back. And so for that process, I do like to have fluoro. I've done a couple just with endoscopic visualization, like in the distal esophagus. You can get a scope down next to it and just watch it. But generally, I'm using fluoro for these. And then the last kind of stent is kind of specialized. It's called Axios, but it's the shape of a dumbbell. We're not using these in too many acute settings. They're designed to connect the stomach to a pancreatic pseudocyst. They're using them to do gastroduodenostomies and drain the gallbladder into the duodenum. So it's connecting two spaces generally. But sometimes the shape lends themselves to particular strictures. So we've used them in esophagogastrostomies or esophagojejunostomies, where it's kind of a tight space at the GE junction or something similar, and that little dumbbell shape kind of holds it in place there. Speaking of being held in place, I didn't mention fixing stents as well. So especially those big, fully covered esophageal stents, they can migrate up to 30% of the time, and then they get lodged in the small bowel, cause a perforation. So it's a big deal. I usually try to put 2 overstitch sutures into the proximal end of these. I had one case where I did 1 and it migrated, so now I do 2. I think the literature may say 3 is better, but that's not surprising. The more you do, it's going to migrate less. But these are kind of hard to get out too. I've started actually not cinching them down all the way. If you really cinch those down, that thing's going to be buried in the mucosa when you come back in a month to get it out, and it's really hard to find the suture and cut it. So sometimes I think a little bit of an air knot might be helpful to get them out later.
Awesome. That was an excellent overview. The last kind of thing that we're going to talk about, last but not least, is the EndoVac, right? So there's probably some resident or trainee on this call who has participated in the care of a patient that has required an EndoVac. And I think the good thing is that one patient probably provided you the skill set, but it is an incredibly useful tool. So essentially, when we are saying EndoVac, putting a black sponge specifically on the end of a nasogastric tube. Again, this can be done through either orifice. Most of the time when we're doing this, this is in the foregut setting, and then actually placing the black sponge attached to the NG tube into a cavity or defect. That's particularly helpful for areas where there's significant amount of contamination, and it can help to provide a source control. So things, where it's used in anastomotic leaks, perforations. I am part of a team that does or takes the esophageal kind of perforations at our tertiary care center. And for, anything, this is kind of a standard part of our protocol because it's a temporizing measure that has very good clinical success in actually healing wounds over time. The thing to talk about and is worth mentioning in counseling patients is that there's really no telling how long you are going to have to require endoluminal vac therapy prior to this actually healing. I typically will tend to favor doing one more exchange than you need. So when the area is granulated and it looks like things are sealed, to do an additional change just to make sure that you're in a good place. I don't personally perform contrast studies on table, though I know people do that and do that successfully. There is a lot of data that has emerged on this technique, especially over the last 5 to 10 years. Steve Leeds will shout him out. He's a kind of a friend of the family, and Dallas has published extensively on this. And his series where he was looking at different areas of the GI tract and applying EndoVac therapy, it took 7 to 61 days to heal these different defects. And so this is something that you have to commit to, and patients need to understand that oftentimes this is the only option, right? There is could be a hole or a perforation or a defect that's too gnarly to close with endoscopic suturing or clips. And then this is an area that takes a commitment over the course of several changes to actually provide a durable result. And so, there are a variety of protocols that have been described with this. Typically, what I do is I'll change the EndoVac twice a week. I think that's pretty standard protocol. So have set days where you go back, remove the sponge, look at the defect, and then cut a new sponge and replace it. Importantly, this is all done under general anesthesia just because you want to protect the patient's airway. So that's definitely worth saying. And again, can be applicable to different areas, things like sleeve leaks and hard to reach areas, but it's certainly a commitment. I'm not sure if anybody else has any further tidbits on this technique, but I know that this is one of the things that I rely on frequently in my own practice.
I think the best tidbit ever is don't put the sponge on before you put it through their nose.
Did everybody hear that?
One time.
Because you can't put a tube, NG tube with a sponge, down like a normal NG tube. So you pass it into the oropharynx, get the tube. I'm pretty sure I've done this with Dr. Hedberg
Every time, like tied the perfect knot, and you got the sponge in there. And
look what I made.
Actually, he'll remember this fondly too. I think the first one that me and him were supposed to do, I was like trying to, have everything prepped, and I had sewed the sponge on the back table, and I was like, "Let's go! I don't want to waste big soup." So good. And he was like, "Yeah, not so fast, my man."
Yeah,
but it's a very useful tool.
Yeah, I was just going to say too, you may have mentioned this, but you got to keep feeding access in mind. I mean, if you're doing this in the esophagus or something, they're not going to be able to eat. You got to leave a tube beyond it. And to go back to my stent process, I was looking into this stuff recently, and there's a company now that's making a stent with a sponge wrapped around it. So you can deploy this in your perforation and then suck on it, and they can still eat through the stent. Wow. So that's kind of a nice development. We may see that coming up the chain at some point.
Well, speaking of the chain, I'm pretty sure they're commercializing EndoVac, right?
Yeah, I think this is that company. They have a couple of products, I think.
Yeah.
Yeah, very neat. So the best part of these types of episodes is doing case-based learning, or at least I think so. So then we can kind of apply a lot of the things that we've talked about. So we're going to go through a few cases that hopefully can give you all a chance to see how we employ some of these technologies in everyday practice. So I'll take the first one. Again, this is for Dr. Hedberg. So this is a scenario that we actually dealt with. So there's a patient who came in from, the famous outside hospital. The guy was found down overnight, started having projectile emesis, went to this outside facility and had a CT scan that showed an esophageal perforation. So the thoracic surgery team accepts this patient. He also had a pretty significant infusion in the right chest, and took him to the OR for first an endoscopy. And I was I guess the fellow, so they wanted me to come down and check out this area. It seemed to be the perfect storm, and I unfortunately knew it, and I don't even think Dr. Hedberg was on call, but there was a linear tear in the distal esophagus, clean edges. We kind of knew the timing of everything. And so my thought at the time is this might be a candidate that was amenable to endoscopic suture repair, so for an acute Boerhaave perforation. But I don't know if you remember that or want to comment on what we actually ended up doing.
Yeah, no, I do remember the case. I think, the main thing to keep in mind with these is, can you adequately wash out the space endoscopically? You don't want to leave a bunch of crap in the chest or get media stenitis. So I think the thoracic surgeon had already decided he was going to do a VATS and wash out the chest, leave some drainage. I think there was concern about being able to get to the space well, to have a really good closure or a good two-layered closure without doing a thoracotomy. So I think it made good sense. Man, I got a good mucosal closure on my side, and he threw some stitches on the muscular side, left some drains, washed everything out. And if I remember correctly, the patient went home after a couple of days. There was no leak. Same kind of scenario. You don't want them eating right on top of that closure immediately. So he left some drains and left Dobhoff. And then, just watched it. Contrast study looked good. So I think it was an appropriate case. I mean, you don't need to do the endoscopic closure there. If it's a smaller or very early tear, then you may feel comfortable just washing it out endoscopically and not doing the VATS. But this guy had been sitting around for several hours, and I think that was the safest way to handle it.
Yeah, it was a win, spared a thoracotomy. So, that's not the everyday scenario. A lot of times by the time patients get to you, it's been, several hours or days, and that really becomes a less good option. But
Yeah.
Trump, you want to take the next case scenario?
Well,
Yeah, sure.
while I had the soapbox, I was thinking I could just go through another case I had recently. It's actually that patient I mentioned with the 6 centimeter stent. So she was a 20-year-old woman, had a sleeve at a children's hospital, and it's strictured. She had like Dobhoff tube in place for like 4 months when I met her. She really did not want to bypass. So I had done one like Heineke Mikulik style stricturalplasty, which actually worked pretty well. And there's some precedent for that. So we talked about doing that. The stricture did end up being kind of long. There was this very tight fibrous band, and that was kind of twisty and a little small after that. So it's kind of a wide Heineke Mikuliks, and it did break down.
Stricture of the
So
sleeve, right?
the stricture of the sleeve, yeah.
Presumably at the angularis.
Correct.
think
Yeah,
I
kind of
got
classic stricture picture. Yeah. So part of the suture line broke down when it was recognized. I mean, she didn't really get ill for a while. It was kind of this kind of smoldering picture. And when we got imaging, there did seem to be a contained abscess cavity. So going by the numbers, we did an internal drain first. I think in this case, it did not work very well because that is more dependent than where we usually have our staple line leaks, which are pretty proximal. So I think her oral intake was kind of going into this abscess cavity. It ended up blowing open into a free flowing perforation. So it went in, pulled out the internal drains because it's no longer appropriate in that setting, did a washout. We stented the perforation on the inside and had drains on the outside. So that was more like an anastomotic leak kind of picture. This is the stent that migrated distally and caused an obstruction of her pylorus. So then we had to pull that stent out, even though that plan, technically could have worked. What we did at that point, there was the perforation had kind of opened again. I had closed it when we put the stent in. I closed it around a peg tube, and that was kind of interesting. So we went through the mouth of the endoscope, past a wire laparoscopically into the abdomen, and pulled it out through a port. And then we pulled the peg through her mouth, or the peg tube through her mouth, and it was just sitting right where the perforation was. And it was kind of, the stomach closed nicely around that. Then we still had her external drains. I put a J tube in. So now we finally had a controlled situation where we could vent the stomach, feed her through the J, and we had the external drains. We were able to remove the external drains pretty quickly. I went back after a month when things had settled down and removed the peg tube. There was still a pretty good gap in the stomach. It didn't look great, and it's still in this dependent area. I was worried about it leaking again. So that's why I was ready with that 6 centimeter stent. So we're able to cover that area, let it heal. We're going back tomorrow or Wednesday to remove that stent. And then I think hopefully she'll be done. We'll be able to get the J tube out. She has not tolerated the stent very well. That is another issue with these things. They can cause quite a bit of discomfort and nausea. So, we try to use them sparingly when you need to.
Yeah, I think one of the. Go ahead, Zach.
If that leaks, though, you're just leaking out the skin, right?
Yeah, it would have been a controlled fistula, but I want to try to avoid that. I want that tract to heal. So I figured cover it up one more time and just let it go.
Sure.
Yeah, I think another important point that you brought up kind of globally is stenting. When you stent an area, always think about what's on the other side of that, right? Like how can you get adequate drainage? Because if you stent an infected area and it's not being drained, obviously that's a setup for failure. But people think, oh, there's a hole, just stent it. But it's not always that easy. So anyway, thank you for the bonus scenario. Trev, you want to take the next case with Dr. Callahan?
Absolutely. So, Dr. Callahan, I got one for you. And this is I guess, collective, real and recent scenario. I will say that my caveat is I'm not in the esophagectomy business, so not my particular case, but this is a patient who is now 7 days post-op after an Ivor Lewis. The patient had been discharged that morning and had previous upper GI, which was negative for a leak and negative drain amylases. They then presented to the ER the night of discharge with shortness of breath, temperature of 101 Fahrenheit, and lethargy. CT esophagram is performed, which reveals an esophageal leak and a small effusion into the right chest.
Yeah, I'm out of the esophagectomy business myself, but it's a good case. Yeah, I think there's a few different ways to go about this. I mean, first and foremost, you kind of have to decide if the chest is something you have to go after or not. Similar to kind of what Mason was talking about before. I mean, if it's not a lot of fluid, if the patient's, not super septic in front of you, you can get away without washing out that chest, but otherwise that's something to look at. But, for me, so what we said, 7 days post-op or so, the other big, point here is how big is this disruption? And in this case, it's 50%. Recognize that there's probably some sort of ischemic issue here. So even if it's 50% now, that could grow. So I think it's a good use for an EndoVac, because EndoVac, I mean, just like wound vacs, we know that they shrink cavities. They help with granulation tissue and wound contracture, and this works endoscopically as well. So yeah, this patient was taken in the operating room, did upper endoscopy, and as I said, there's a 50% disruption in the anastomosis, so an endo was placed.
Excellent. And so a fairly common thing that can happen after these, and we'll say for the sake of argument that this is what happens, is that the patient then strictures down at that site where kind of that disaster happens. If they were to present to your clinic, let's say a couple months after discharge with profound dysphagia, how would you handle that?
I mean, I'd work it up. I'd probably get a swallow study, a double contrast esophagram, get a sense of where the problem is. That being said, common things being common, there's a problem with this anastomosis before. Not surprising, there's a stricture now. Ultimately, take this to the endo suite and evaluate. And if it's an anastomotic stricture, which it likely is, I would balloon dilate that. I've steered away from the savory dilations lately. Balloons worked well. I like to be able to see what I'm dilating as I go. So that's probably what I'd do.
How long do you hold your dilations for, Dr. Callahan?
I do 1 minute.
1 minute. Okay.
Yeah. So what Dr. Krause is getting at,
We got that on record.
Historically, people would hold it for like 2 seconds, and I found an article in Fellowship that suggested improved outcomes with 3 minutes, and I ruined basically the fellowship and all the efficiency at North Shore Hospital after. So the guys haven't forgiven me yet, but what do you guys do? Are you still doing 3 minutes?
I do 3 minutes because of you.
You do 3?
I often do. I've started being a little more selective where I actually watch to see how much the gauge is dropping. If you have to keep chasing the pressure because you're actually stretching something, I keep doing that till it's done. Sometimes that's 5 minutes. If it stops stretching after a minute, I stop.
That's such a smarter way to do that, Mason.
Polling the group, does anybody do Kenalog?
Yeah.
No.
I saw that in pediatric surgery in residency, but no.
Makes sense.
I was going to ask about that too. I've done it once. I think the data says you're supposed to do it early. You get these fibrotic and anastomotic strictures. Your best bet is to do it the first time you dilate it. I have not been doing that yet, but I think that, the one I did was very easy. I think there's no reason not to do that.
Just like some mucos just get a needle, inject kind of thing.
Yeah, you want to get into the fibrous band. Then the other one I was going to bring up is the stricturotomy. Anybody's doing that?
Yeah, I haven't done it,
but
I've read about it.
Yep.
Yeah, no, I mean that's pretty easy too. I try to be pretty favorable or selective with those as well. If you have one of these strictures where it looks like a thin band, like a Schottky ring or something coming into the lumen, then I'm very comfortable whacking that with an eye knife or some kind of needle knife in a couple spots. You're trying to just disrupt the fibrotic band, and then in theory you should have a more controlled dilation with a smaller risk of perforation, actually, because you're like forcing it to dilate in 5 spots instead of like fracture in 1 spot potentially. So you still do a big dilation afterwards, which feels scary, but it should be safer actually.
Yeah, I think one of the primary data points on that is decreasing the time to re-intervention. So it gives you, a little bit more time for patients to be symptom-free or lessen their symptoms, but that's
And
great.
you're eye knifing mucosa, theoretically stopping at.
No, you want to
So-
see the fibrosis. You're trying to see the fibrotic band and like actually cut into it. So, these like kind of long, tapered strictures is not a good option, but a very short one that's coming into the lumen, you can just whack it and actually see the fibrosis.
And you don't have to close that or anything.
Mm-hmm. Yeah, just leave it.
Excellent consideration. All right, Dr. Hedberg, our last scenario, you want to take it with Dr. Crafts?
Yeah, that's for Dr. Kraft. So a patient is referred to you for endoscopic mucosal resection of a 2-centimeter gastric polyp. You complete the procedure in standard fashion. I might want to hear what fashion you chose to remove the polyp. However, after the resection, you do have a small full thickness perforation. So it's a sub-centimeter wound. It's fresh, clean edges. So how do you choose to remove the polyp, and how do you close the hole you left behind? And I've done this myself. There's a couple options.
Sure. I know my whole response to this may be like heretical for this group of people here, but I would probably hot snare this. You could totally EMR it, and I think that's not unreasonable, but I think you could do lift with like an epi, like a dilute epi solution, and just hot snare it. It would probably be totally fine. But then we'll fast forward to the point where it's not fine and there's a hole. And I think the first thing to point out is that, it's always good practice to examine your kind of resection bed, not only for a perforation, but also for bleeding. That would be the other thing, particularly when you're into the submucosa where you can run into trouble, like specifically with delayed bleeds. So presuming you would find a hole, there is actually some guidance to this, and I will totally take the heat if I'm the first person on Behind the Knife to quote gastroenterology literature, but there's an AGA clinical practice update from 2021. And so admittedly, there is, expert guidance on this, but in reality, these are very kind of location and scenario specific, management practices. But for small defects, or basically those that are smaller than 2 centimeters in size, you could consider it would say that you can consider either through the scope or over the scope clips. And I will say personally that we do sometimes, if you have a full thickness, hole in a myotomy or something, occasionally we'll close the mucosa with just through the scope clips, and that is generally fine. But if I had just made an iatrogenic perforation, probably the way you would be most confident in closing this full thickness would be with an over the scope clip. And that's probably what I would reach for first. For larger defects, particularly those kind of approaching and beyond 2 centimeters, that's when you want to think about endoscopic suturing, and that way you can get primary closure for these as well. You can also consider stenting in location appropriate scenarios like the esophagus and things, either as an adjunct to suturing it closed, or if you can't get full primary closure, although that is definitely less ideal, and plan B. And then after the patient's off the table, there isn't really a defined correct way to manage them. You certainly can consider performing an upper GI depending on your level of comfort and confidence. But I would definitely personally keep this patient for overnight observation and, give them liquids and kind of slowly progress their diet and make sure that, clinically they weren't having any issues before letting them go home.
Very thorough answer. I love that. Anything else anybody would add here? I would handle it the same way. If not, it's Dr. Zach Callahan's time to do the quick hits for Behind the Knife.
I can't believe I'm doing quick hits. I don't know what I did to deserve this, but I'm absolutely thrilled. Thank you. All right, quick hits. 1, endoscopic solutions to surgical complications can often mitigate the need for more surgery. 2, endoscopic tools for managing complications include, but are not limited to, endoscopic suturing, EndoVac, stent placement, and the use of clips. 3, endoscopic suturing is a particularly versatile skill. It can offer the management of a wide range of defects, particularly those without significant contamination and are clean and viable. 4, EndoVac therapy is done by applying black vac sponge to the end of an NG tube and endoscopically, and is very beneficial in the setting of contamination. 5, when considering endoscopic stenting, it's important not to stent and isolate an infected area.
Excellent. Thanks everybody again for tuning into this episode of Behind the Knife. It's our 4th in a series of 6 episodes. I will make some videos to accompany this podcast, but for now, this is the BTK Surgical Endoscopy team reminding you to dominate the day. Thanks so much. For additional training and education on this topic, Boston Scientific's EduCare platform provides online access to a wealth of educational and training content all in one convenient place. Visit educare.bostonscientific.com, that's educare.bostonscientific.com, to start your learning journey today.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.